Nearly 2 years into the pandemic, we continue to rely on scientists to find the most effective vaccine regimens and treatments for those infected with COVID. But this all proceeds in an environment where a significant part of the population live on the edge as outright science deniers. And on the front lines of it all is my guest. Dr. Rochelle Walensky is the director of the Centers for Disease Control and Prevention. She served as chief of infectious diseases at Mass General Hospital and a professor of medicine at Harvard Medical School prior to that appointment. Dr. Walensky, it's great to see you. Thanks for your time.
Thanks so much for having me, Jim.
So in the last couple of days, Dr. Fauci said he expects Omicron to peak in mid-February. If he's right, what does that mean for a return to even semi-normalcy in the near future?
Yeah, really important question. So we're starting to see in places like Boston, like the Northeast, where cases really soared over the last several weeks, that they're coming down actually quite dramatically as well. We are seeing in other areas of the country that the cases are continuing to rise. So areas in the upper Midwest, for example, cases continue to go up. So as a country, we're coming down, but we're not fully down yet because we're in different parts of this surge in different parts of the country. Everybody is very interested in how Omicron will come down, and then eventually what will happen after Omicron naders. And we're watching that very carefully. Ultimately, I think we really need to look to our hospitals as a barometer. How are our hospitals doing? How is our workforce there? How are our beds there? Because right now we need to make sure that we keep the medical centers able to take care of people, not just with COVID, but with routine medical issues as well.
But how do we ever get to the promised land when the fully vaxxed number is still stuck at a little below 2/3? The fully vaxxed and boosted number is pathetic at somewhere near 25%. If those don't move dramatically, we never get there, do we?
Yeah, we can. I would always say that our safer way to get to immunity is through vaccination and not through disease. But ultimately, what we're seeing now with Omicron is that many people are getting to disease as well. Our booster rates nationally are around 40%, so we're making some progress here. But I think really important to note is data that just came out of the CDC on Friday that demonstrated the real benefit of getting a booster shot in the context of Omicron. So we saw that if you just had your primary series, 2 doses of vaccine, you had 57% protection from being hospitalized if you got infected with Omicron. However, if you were boosted, that protection went all the way up to 90%. So really, really important to get that booster dose to protect you from hospitalization.
Early in your tenure as CDC director, you put out a statement saying racism is a serious public health threat. Is it any less a threat in January of 2022 than when you made that statement?
No, I will say I made that statement in the context of COVID and in the context of so many other health conditions across this country. We can look at climate health, we can look at sickle cell disease, we can look at maternal mortality, diabetes, hypertension, cancer, and all of them affect racial minorities more so than the Caucasian population. And right now, I think we need to focus on COVID, but also on all other areas of health to protect and make sure that everyone has ample protection and safety from health threats.
But ultimately, it's not just about health and all that list of conditions you mentioned, Doctor, is it? It's about your public safety, your public schools, the affordability and decency of your housing. All of those are part of the public health mix, are they not, particularly for lower income people in this country?
Absolutely, and I think what you're speaking to is social determinants of health, because our health is very much related to where we eat, where we work, where we play, where we worship, and all of those collectively come together to provide, the social determinants where we live, the social determinants that so very much impact whether we have access to health and whether we can get treated for the health conditions that we have.
Doctor, you recently took heat for reducing the isolation period from 10 to 5 days and not suggesting that there be a negative test on the way out the door. I assumed at the time that the reason for the former was a combination of science and economic reality, and the reason for the latter was a function of the reality that we just didn't have any tests. Was I not right?
So when we put out guidance, we have to do so in the context founded absolutely on the science that we have at the time. And sometimes that science is imperfect, especially during a pandemic. But all the science that we have at the time, and we have 2 years worth of science in COVID-19 right now. We also have to look at the epidemiologic profile, what is coming. And this was many, many cases of Omicron that were coming to our front doors, to our workforce, and to health and public health. And then, of course, we have to see what's implementable, what is doable. We certainly want to put out guidance that the public can use and trust. In the context of the question about testing, one of the real questions here was, how do these tests, how are they authorized by the FDA? How are they best used? And so it was in the context of all of those pieces of information, science, epidemiology, feasibility, and then what these tests were used for that were the foundation of our decisions.
Regardless of what one sees as the appropriate use for rapid tests, there seems to be a general acknowledgement in the world that you lead on how important they are. Are you content with the state of affairs? I know it's well intended, but 4 tests to every household by the end of the month doesn't seem to cut it for me if rapid tests are so important. Does it for you?
We have more work to do. We have to make sure that tests are readily available, that people can get a test when we want them. I do want to remind folks that rapid tests are not the only mechanism by which we can get tests. We have PCR testing in over 20,000 sites, and we continue to scale up rapid federal PCR testing sites. We have rapid tests that are available online. We have rapid tests that are available in community health centers, and we've added this now to 4 tests being sent home to households. But as you say, we need to make sure that tests are immediately accessible, and we have more work to do.
Do you bristle when you read the constant drumbeat of the messaging isn't right at the CDC, the messaging isn't right at the Biden administration? Are they fair charges in your estimation, Doctor?
My responsibility is to review the science in real time. The science is now coming into us via preprints. It's coming into us at a pace faster than ever before. And then my responsibility is to take that science, to evaluate the current context, to make decisions and to communicate those decisions with the incredible subject matter experts that I have at the CDC, providing me the guidance and the foundation for those decisions.
The first time I ever heard of you, obviously, you were at the MGH. I'm assuming that you were not the subject of a lot of public criticism, probably not a huge amount of private criticism either. How are you dealing with the fact that you get it virtually every single day from the left and the right? How hard is that?
I think that I have to acknowledge the criticism and see where and how I can do better. We as an agency can do better. But right now, my North Star is making sure that the science and the information that we have lead us out of unprecedented times. I've never had my motivations questioned when I entered a patient room. My motivations are still the same: to protect public health, to protect the safety of all Americans.
But how hard is that? That's got to be a total misery for somebody who's, I'm serious. I mean, is it not? Certainly, there's a lot of public splashes across the pages, but there's an incredible amount of quieter support from people who mean a lot to me, people in healthcare, people who have been my colleagues for years, and that is, the voices that I have to address because they're the science-based voices. I'll take that as a yes, that it is misery. At least that's the way I translate it. Your colleague, Dr. Fauci, said on 60 Minutes and elsewhere, he not only has gotten criticism, but death threats. Have you?
There's been more and more attention, and I'm working through it.
Okay. So one of your early interviews, I remember reading, shortly after you were picked, I think, by the president, you said you wanted to make sure science will be heard again during your tenure, were your words. And it seems to me that thanks to the homicidal COVID behavior of the former president, people like RFK Jr. today, the far-right media, it's not surprising when you look at a Gallup poll from a few months ago and see that fewer than half of Republicans in this country have confidence in science, down 30 points from a couple of decades ago. I assume, even if that's not formally in your job description, you feel it a responsibility that one of the legacies of your time is not the death of science in this country. What do you do to convince people that science changes, but it is real and it's critical to be believed in?
Yeah, well, first, I think all of our decisions have to be motivated by that science, and all of those decisions have to be transparent. We're very transparent about how how those decisions are made. We've put out many, many scientific briefs. We have had media conversations. So we really do have to be very transparent about how those decisions are made. And sometimes they're complex. They're not so easy in a 2-minute soundbite. They're complex about how we unpack that science. In terms of how you convince somebody who might not be vaccinated to get vaccinated, I go back to the bedside. The way you talk to patients is by listening, doing more listening than talking, and to understand what their concerns are. And I think we can't really group everybody as saying these people don't want a vaccine and these people do. I think what we really need to do is talk to individuals as individuals and understand what their concerns are, what's motivated their decision. And interestingly, when you take people one at a time, oftentimes you can really understand what has been limiting them and what has influenced their decisions, and you might be able to provide them with information to get them vaccinated.
You're a far kinder person than I. Dr. Walensky, thank you so much for your time. I really appreciate it.
Thanks for having me.